Welcome to AETCM, the emergency medicine channel.
Yeah, please.
A 38-year-old male, no previous comorbidities, presented to the ER with complaints of fever, headache, and vomiting of 2 days duration. On our initial 10-second assessment, patient was conscious, oriented, and obeying commands. Coming to airway was patent, no secretions. Coming to breathing, air entry bilaterally equal, respiratory rate of 18 breaths per minute, saturation of 98% in room air.
Okay.
Coming to circulation, BP of 120/80 millimeters of mercury, pulse rate of 98 per minute. 2 large bore IV cannulas were inserted during this point of time. Coming to disability, GCS of E4, V5, M6, pupil bilaterally equally reacting to light. Coming to exposure, temperature of 100.8 degree Fahrenheit and GRBS of 109 milligram per deciliter. At this point of time, injection paracetamol 1 gram IV stat was given. Coming to adjuncts of primary survey, CBC CRP was taken showing a CRP of 6 and total count of 6000. VBG was taken, were no acid-based disorders. We reassessed the patient after the injection PCM and still the patient complains of severe headache. Coming to ample history, a 38-year-old...
So, at this point, we have a middle-aged kind of a person with history of fever and headache who was kind of febrile on arrival also. No other systemic findings were there, right?
Yes.
Okay. What are the differentials, broad differentials you are going to consider at this point? And you have a preliminary lab which is saying that there is CRP is not that high, but counts probably slightly on the lower side, 6000. Again, within normal limits probably. Yeah. Okay. So what are you going to consider at this point?
So one is short febrile illness, maybe that can be precipitating a tension headache or an acute attack of migraine.
Most of the times it is going to be a viral kind of infection with predisposing to other symptoms. Fine. Anything else?
At present no history of any trauma.
Okay.
But can be meningitis or any CNS involvement.
Okay. Okay, definitely that will be one thing which you are going to keep in mind. And also non-infective causes, because CRP is negative at this point, right? So always think about other primary CNS non-infectious etiologies also. Okay, fine.
Coming to ample history, a 38-year-old male, no previous comorbidities, present to the ER with complaints of fever, headache, and vomiting of 2 days duration. The patient gives a prodromal phase of fever and loss of appetite 5 days back, which subsided on taking medications. Now he presented with high-grade fever associated with chills of 2 days duration, which was not subsiding with analgesics and antipyretics. He also gives history of associated headache, bifrontal region, and also associated neck pain. The patient also gives history of generalized tiredness and 2 episodes of vomiting. No history of any blurring of vision, altered behavior, photophobia, weakness, any seizures, no history of any trauma, no other associated symptoms, no aggravating or relieving factors. Coming to medication history, no history of any on medications. Coming to past history, no history of any similar episodes in the past. The last meal was taken today morning 7 a.m. And coming to systemic examination.
Before that, any more history? Because it's a case of
travel
fever.
History, no travel history was also there.
Okay. No travel history, no history of similar complaints in any contacts?
No, sir.
Not there?
No, sir.
Okay.
And the patient was not an alcoholic or a smoker, not on any drugs also, sir. Coming to examination, no pallor, no icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, CNS examination, GCS was E4, V5 and M6. Bilateral pupil equally reacting to light, power 5/5 on all the 4 limbs. Coming to signs of meningeal irritation, there were neck stiffness that was noted, but no Kernick's or Budinsky sign.
You want to explain how you do these tests?
Sir, in Kernick's sign, we will ask the patient, we will flex the hip of the patient and then extend the leg. Then due to the pain, the patient has flexion of the head and hip also, sir.
Where is the pain?
In the back side, sir.
Okay, fine. The other one?
Budinsky sign, we will ask the patient to flex the neck and there will be pain in the lower limbs.
Yeah. Usually it can lead to flexion of the leg automatically. Yeah. Fine.
Then coming to
So no other signs other than neck stiffness.
neck stiffness.
Okay. What all things can have neck stiffness?
Some one basic thing in elderly age group, it can be cervical spondylosis.
Spinal issues can cause. Okay.
Cause neck stiffness. We have to rule out that first. And other symptoms can be anything like any trauma related causing any head injuries can also lead to traumatic
So
brain
basically,
injuries.
any irritation in the brain can cause. It is not something which is very specific to meningitis. So remember that any irritation can cause trauma, blood in the brain. Okay, fine. Continue.
The other systemic examination was within normal limits.
Okay.
So we were suspecting a short febrile illness, probably viral and probably involving the CNS systems. We were initially we have given injection PCM and still the fever and headache everything is persisting. And
Okay. So you have fever with headache. Anything extended general examination? Anything
general examination. Pupils are equally reacting.
beyond the pupil? Fundus.
Fundus. Papilledema
Okay.
may be
This
notable.
definitely, ideally, the patient, even if you don't have any imaging, definitely fundus has to be looked into this patient. Okay, fine. That was not checked. No problem. Continue.
Then since the fever and headache was persisting despite we have given injection PCM and also we have given injection tramadol also, sir. But despite the headache and fever was persisting, so we insisted on taking suspecting a meningitis like picture, sir. Since neck stiffness was also there with the acute presentation of 1 to 2 days in a young patient with fever, headache and vomiting. So first step, as we have given steroids as the first line of management, sir. We have given injection DEXA along with suspecting meningitis. So first line we have given injection steroid followed by empirical therapy of injection ceftriaxone, sir. And then second line.
Okay. It is little hard to justify giving steroids at this stage because we will definitely discuss in due course what are the indications of steroids in meningitis, and it is very limited, to be very frank. So fine, there is some justification for giving steroids also. So you have given antibiotics with steroids, and
then we have sent the patient for MRI brain with contrast, sir.
Okay.
And MRI with contrast, no leptomeningeal enhancement, no other features were suggestive.
So a contrast study of brain was negative.
Negative.
Okay, fine.
Then we planned the patient for LP, sir. Since it was negative, we were planning to take the patient for LP.
Okay.
By that time, our first dose of steroids, antibiotics, and antivirals have gone, sir. Then we have taken the patient for LP, sir. After taking consent, we prepare the patient position. Then we went with LP, sir.
Okay.
And
so the sequence of management plans what we have done. So ideally, if you are planning an LP immediately, you can wait for that for some time. As long as the patient is not very toxic, no signs of like a seizure and things like that, definitely waiting for some time is okay. And if you are planning for an LP, all you need is a CT brain plane. If you are suspecting some other intracranial pathologies which you need a diagnosis with an MRI, then definitely MRI is indicated. So if you are suspecting meningoencephalitis, ideally you can take a plain CT and go ahead with the LP. So why is a plain CT advised?
just to rule out raised intracranial.
That's all we need to know. Okay, we should be able to identify there is no contraindication for an LP. That's all we need. Okay, so you do a plain CT and then you proceed with the LP. LP, what are the things you need to look?
First, we need to any contraindications for it.
It is not there.
Then we take
Also look for anticoagulation kind of. If the patient's INR is very much elevated, the platelet is very low, those kind of things you have to take added caution before doing the LP. So while doing the LP, in most cases always look for the opening pressure. Okay. After that you are collecting the samples. Okay. Now what all things you will be sending from the LP?
we will be sending the cytology and also cytology basically number and type of cells. Then we will sending the cultures, if possible, just a gram stain we will send. And
What are the three main things?
cytology is one. Cell, protein, sugar.
Tell those things. So and simultaneously you have to look for one more thing, no? While you are collecting glucose.
Corresponding glucose.
Yeah. Okay.
PRBS as
So these are the primary three things, no? You have the cells with the differential, you have the protein, and you have glucose. Okay. Now, based upon that, how will you come to your diagnosis?
Based on initially we will differentiate into bacterial, viral, tubercular, and fungal. In bacterial, coming to the cytology, the cells will be usually more than in thousands with predominant neutrophils. You can also see sometimes a slight elevated opening pressure with low glucose and increased protein in bacteria. Whereas coming to viral cells in the range of less than thousands only, but that too predominant lymphocytes.
Hyperacute phase, it can be polymorphic also. Remember, it is usually after the second and third day that you will get more of a lymphocytic predominant. So don't always rule out viral etiologies from the initial findings. Okay, yeah. So you have lymphocytic, which could be, again, continue.
In lymphocyte predominant in virals. Opening pressure can be normal or slightly elevated. Sugars can be normal, and proteins can also be normal, slightly elevated in virals.
Yeah.
Coming to tubercular, the main characteristic feature is elevated proteins, a very high level of proteins with lymphocytes predominant.
So what happens to the glucose and protein in viral?
In viral, it can be normal or slightly elevated.
Which one?
In viral, sir.
Which one? Protein or glucose?
Proteins can be normal,
Protein?
slightly
Yeah.
elevated.
Protein can be mildly elevated in this, and also glucose, usually it is normal, very rarely it is. Yeah. Then
Then viral TB, it's like glucose on the lower side. Proteins are very much elevated. Counts varying from 100 to 500 with predominant lymphocytes.
okay, fine. So that is with the three main things. After that, you are going to send for the gram smear, right? So what is the information you are looking forward from the gram smear? It could be either a gram positive or a gram negative. So based upon that, you can kind of tailor the antibiotics. Okay. Then what else?
Any cultures?
So what if you are seeing blood?
Traumatic.
Okay. First thing is, most common thing is traumatic. Okay. Then any SAH? Definitely you are going to get blood. But in an infective kind of situation, a patient who has already in an MRI, you are seeing certain findings which is suggestive of infection. The question I'm coming to is, can blood in CSF indicate an infection itself? Okay. In certain kind of encephalitis and all, once they go into tissue necrosis, then you can have blood in CSF as part of infection itself. Okay. So once you are collecting sample, like if it is how will you differentiate between a traumatic tap and a pathological blood?
Initial first sample, there will be, if traumatic, then initial the first few drops will be traumatic.
If it is traumatic, the initial will be more kind of reddish, and as we proceed with it, the color usually changes, and the last samples will have a lesser. And there is a correction factor for how, if at all the samples you feel is traumatic. Can you correct? Can you really find out that it is the white cell is because of the tap or because of the traumatic tap, or is it a pathological thing?
Serial.
No. So basically there is a correction factor. So say this much 5000 RBC is there, means this is the amount of WBC you are expecting in that. So you have to go for the correction factor and see whether the total count is beyond that. That will be one way of, even if it is a traumatic tap, there are ways in which you can say whether there is real leukocytosis or not. But remember that protein can go up in a traumatic tap itself. Okay, fine. So that is with the CSF tapping and basic idea of a CSF analysis. Okay, anything else from CSF? And definitely you need to send for cultures. In immunocompromised patients, difficult kind of initial round of workup is over, you're not getting anything, always send for PCRs also. Okay, fine. After CSF?
In this patient, sir, CSF study, the cell count was 682, sir, with predominant lymphocytes. CSF cytology showed mixed pleocytosis, sir. CSF glucose was 65, with CSF protein of 50.
CSF glucose 65 with corresponding sugars of?
Normal, sir.
75, 80 kind of.
85.
Yeah.
Sir. CSF ADA was 1.10, sir.
1.10. Okay.
So it gives a picture of viral picture, sir. So we started the patient early on, and then correspondingly we will start the patient, continued with antiviral, sir. We started on acyclovir 10 to 15 mg per kg QAH.
The acyclovir usually it is 10 mg per kg is okay, fine. Right. So you feel that this is a viral meningitis. There was no altered behavior for the patient, so you are limited to meningitis. There was no imaging findings suggestive of anything. Fine. So we'll come back to the imaging part once more. what is the imaging finding you are expecting in meningitis in MRI?
Any leptomeningeal enhancements?
Okay. So first thing is going to be leptomeningeal enhancement, where you see that the contrast image will be more kind of an enhanced, and also in if you are suspecting a fungal tuberculoma kind of thing, definitely a ring enhancing kind of appearance can also come up.
Basal exudates also in tuberculosis.
Yeah. But viral things, it could be just flare hyperintensity syndrome. So there it need not be your typical contrast enhancement. Okay. Is there a problem of doing an MRI after LT? You can get pseudo what we say, like contrast enhancement kind of picture. Okay, so once after the LP, if you are immediately doing the MRI, there can be a kind of little difficult to figure out whether it is really contrast enhancement or it is post LP kind of changes. Okay, fine. So that is with the imaging part. We'll come back to steroids. So as per recommendation, what are the only two situations where DEXA is indicated in a suspected case of meningoencephalitis?
One is to reduce edema, sir.
That is limited to one organism. TB and strep pneumoniae. Okay, the evidence for steroids is limited to strep pneumoniae. That is why. What is the use in strep pneumoniae?
Because the capsule, once we give the antibiotics, if we give the antibiotics initially, the capsules will rupture. That will trigger inflammation and causes edema. To prevent that edema, we will give
that evidence is only for this specific bacteria. Okay, and when should you give it?
Within before starting the antibiotic, 1 hour.
Usually at least 30 minutes before the antibiotic, or at least along with the antibiotic. What's the dose?
10 mg.
Yeah, it's usually 0.15 mg per kg into divided doses, Q 8th hourly. Okay, so that is the dose of DEXA, again at least for the initial 3 to 4 days. Okay, and as you told in TB it is a different kind of thing. TB, it is for preventing sequestrations and septations and for better drug delivery. Okay, that is in tuberculomas and things like that, dose of role of steroids. So the evidence per se is limited to only these two conditions. Okay, coming back to organisms, what are the other bacterial organisms which are well known to cause meningitis?
Sir, it depends upon the age group we will divide.
Okay.
Less than 1 year, the organisms are like Streptococcus agalactiae, Enterococci, and also Listeria can be seen. 1 to 2 years, we can see H. influenza, Streptococcus pneumonia, and Pneumococcus Streptococcus pneumonia can be seen. 2 to 50 years age group, you can see Neisseria meningitis, Streptococcus pneumoniae as the most common organism. And more than 50 years, along with this organism, Listeria has also to be taken into concern.
Okay.
And if any CSF, any surgeries or any is done, then you think about also Pseudomonas also in such cases.
And more than Pseudomonas? MRSA.
And MRSA.
Okay, methicillin resistant star or MDR gram negatives including Pseudomonas. Okay, fine. So that is with the organisms specific to bacteria. So what is the empirical antibiotics?
Empirical antibiotics are initially for gram negative. We are suspecting mainly gram negative, so we will give injection ceftriaxone 2 gram IV BD, sir, as the doses. And for gram positive and slight MRSA coverage, if we are suspecting, then we have to give vancomycin 1 gram IV BD, sir.
It is usually 15 to 20 mg per kg into thrice daily kind of dosage. Okay, that is with vancomycin. Or
in immunocompromised patients is suspecting Listeria, then we will also add ampicillin as 2 gram Q4H, sir.
Okay, not only immunocompromised, extremes of age. Anybody more than 60 years of age, definitely you are justified in starting on ampicillin empirically itself. That is for Listeria coverage. Then with, as you told, post-op, patients with shunt and all, definitely a higher MDR cover is usually indicated. A broad spectrum gram negative cover is definitely indicated. If you are going for carbapenem, it will be 2 grams. Okay, meropenem. Fine. And coming back to viral. Viral, what is the only organism for which antivirals are, like evidence is there?
Herpes simplex virus.
Herpes is the only place, and what is the antiviral?
Acyclovir.
Acyclovir. What is the dose?
10 to 15 mg per kg Q8H.
Okay, and how long you have to give?
7 days.
No, it is, the recommendation itself is for 14 to 21 days. Okay, it is 2 weeks to 3 weeks. But again, there is some literature to show that that may not be enough. Okay, so there are some recent studies which say that you can go for viral PCR at the end of the treatment and make sure that there is no residual PCR present. To guide duration, if the symptoms are not over, there is definitely a role for prolonged course of antivirals. Okay, so that is with acyclovir. Now, what are the usual complications you are going to expect with meningoencephalitis?
So one is acute hydrocephalus can be seen.
That is more common in tuberculosis. Okay, fine.
Then we can see SIAD, hyponatremia can be seen.
Okay,
Then seizures itself
good.
can be seen.
Okay, seizures is more towards?
Encephalitis like pictures.
Okay, fine. Then?
Impending herniation can lead to edema. Edema can lead to impending herniation, sir.
Okay, okay. What is specific about meningococcal meningitis?
Shock, sir.
So what's the
presentation
yeah,
syndrome, sir?
yeah. And what is the usual?
Hemorrhage.
Yeah. What's the usual presentation? It will be with
Hypertension
and rashes. No?
can be
Yeah. Okay. So that will be one differential you need to consider, right? Bacterial, with patient presenting with high spiking fever with rashes. Viral, anything else other than HSV?
Enterovirus can be there,
Good.
sir. Then in HIV patients, immunocompromised patients, cytomegalovirus
Okay.
can be there.
Something which has been usually told to be more in Alappuzha and all. What about Japanese encephalitis?
Japanese encephalitis.
JE. Okay. So these are certain kind of viruses you need to keep in mind. Okay. Now there is a lot more. There is a lot more. Rabies, measles, those kind of things can also have CNS manifestations. Mumps. Okay. So that is with the organisms and the basic line of management. We have covered the role of imaging also, right? Okay. So so refractory kind of meningitis. Is there anything else? Like meningitis is not improving, the patient has abscesses and things like that. So that is a situation where there is some role of intrathecal kind of delivery of antibiotics. Okay, so that is very limited. There is not very strong evidence. It's more like a salvage kind of therapy where the patient has already not responding to conventional kind of measures, has gone into ventriculitis kind of picture, hydrocephalus, neurostructural neurological problems. There is some evidence to go for intrathecal kind of delivery. Okay. Yeah, I think we have covered reasonably. Anything else? So what happened to the patient?
The patient was then started on acyclovir, sir.
Okay.
But gradually, 2 to 3 days, the patient's symptoms improved. There was no signs of any impending herniation. The fever, headache, everything subsided. And we sent back the patients on acyclovir, sir. 2 to 3 weeks acyclovir we have, sir.
Okay. Meningitis, anything else? Like recurrent meningitis, what are the things you need to look for?
Any autoimmune?
Okay. Bacterial kind of picture, recurrent. So always look for integrity of base of skull. Okay,
CSF
patient
leak.
can have CSF leak and things like that. That is one reason where there can be, patient can come with recurrent meningitis kind of picture. Okay, anything else? Well, share.